right, welcome everyone. It's 12 p.m. noon in Eastern Standard Time, so we're going to get started. I want to welcome everyone to our webinar titled Thinking Outside the Box, Implementation of a Virtual Fall Prevention Clinic, facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman. I am the Knowledge Translation Coordinator of the Fall Prevention Program at Parachute. Parachute now sponsors the Fall Prevention Communities of Practice Loop Junior, along with the annual Fall Prevention Month campaign, which is starting November 1st. Before we begin, I just want to cover a few housekeeping items. During the webinar, if you have questions about technology, please type them into the chat box. My colleague Marguerite Thomas will be monitoring this. If you have questions for a presenter about the webinar, please submit them through the Q&A box. They will be answered at the end of the webinar, and you'll only be able to view questions you have asked, not questions posed by other participants. This webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week, along with the presentation slides. You can view previous webinar recordings simply by heading over to the webinar page on Loop and clicking on Archive Webinars, but you can also access archive webinars from the Services drop-down menu on the home page of Loop. I would like to now introduce our presenter, Ronda Field. Ronda is a physiotherapist with the Fraser Health Authority Injury Prevention and Assessment Team, the Falls Prevention Mobile Clinic, and the Healthy Bones Clinic. For a complete bio on Ronda, please view the Loop event page or the Zoom webinar invite. So without further ado, please take it away, Ronda.
Okay, thank you. I'm going to stop your screen share and start mine. So welcome everybody to today's presentation. Thank you to Loop for having sponsored this. I actually had a different presentation scheduled for Loop, and then we had the pandemic, and then we had a change in Loop. So here we are down the road, still talking. Before we get started today, I'm just going to go through what I see as the agenda. I want to take a minute or two to think about reconciliation. I'm going to give you a bit of an overview about the Mobile Falls Clinic, which is our typical way of working, and then the development of the Virtual Fall Prevention Clinic, a little bit about sort of the criteria, I guess, and some of the things that we talk about in the clinic and the referrals that we make. We're definitely, the feedback is actually participant feedback from the people that have actually attended this clinic. So I am a privileged settler on the historic and unceded territory of the Kakite First Nation. This is one of the nations that has no land rights, and there's an interesting documentary available on the National Film Board site that's called A Tribe of One that talks about Chief Larrabee's. She was actually raised thinking that she was not Indigenous, and so she went on quite a personal journey when she learned about her upbringing. But meanwhile, I work for Fraser Health, and we provide services on the traditional unceded territories of about 32 First Nation communities. We have the Tsawwassen, the Nklamax, and the Shtolo, and lots of different communities and affiliates like the Kwantlen and the Coquitlam and so on. We also have 6 Métis Nation chartered communities within our area. And we've had a lot of discussion recently with the most recent Truth and Reconciliation Day and so on. And I want to give people just a moment to think about what reconciliation actually means to you. And then I'll just go into the history of our clinic. So the Mobile Falls Clinic started in Fraser Health in about 2007. So what happens is we have a very, very small team. So there's myself, we have a coordinator, we have different students that join us for 8 to 12 months at a time, and they're generally students from Simon Fraser University, and they help us with a lot of the background administrative type stuff. We have ties to pharmacists, we have ties we have nurses that have helped us in the past, but we don't really have, it's a very small team. It's basically 2 of us plus a student. We go out to local community centers or senior centers or libraries or any place that's an easy community space that we can access our clients. We generally spend 1 day a week somewhere in our health region. So our health region is actually quite large. If anybody knows BC, we cover the area between Burnaby and Boston Bar, which is north of Hope. So it's a geographically quite large region. It would take a good 2+ hours to drive from one end of our health region to the other health end. So we generally spend 1 day a week. Having said that, we're just started back into real clinics, and we've done 2 this week and 2 last week, and we're really trying to catch up. When we have clinics, the clients book an appointment. It's not a drop-in thing, and the appointments take quite a while. It takes at least an hour and a half. We're seeing about 500 to 600 clients a year, which is a fair number. And we have had in the past a variety of different adapted clinics. So we've gone into the assisted living, several assisted living facilities, and we've done clinics for their clients. We've done some that were language specific. We had a Punjabi one at one point. I think we've had a Chinese one. We've had several French ones. So we've tried to adapt the clinic to the population that we're serving. So you can see on the map there, that's what I was saying. We have a fairly large geographic area. So the green is Burnaby, and then Vancouver is the next city over. So because we're Fraser Health region, we're not part of Vancouver Coastal. Having said that, we do get a lot of Vancouver Coastal clients that attend our clinics in Burnaby and sometimes in some of the other areas. So this is basically what our mobile clinic looks like. We have some information that we collect from them in the intake. They go to, it says kinesiologist station because we used to have a kinesiologist who did this, but now it's done by our coordinator and our students, the testing. So the testing that we do is a fall risk assessment using the short form PPA. We do postural blood pressure. We ask them questions about pain and falls history and so on. Then they meet with the pharmacist who does a full medication review. They talk about bone health. They talk about a variety of different things, continence and so on. Then the client comes to me. I go over the results of the testing that they had done, because in the time that the client is with the pharmacist, our team will print out the results so that we have a graphic, which is really nice. We talk about the results. We talk about strategies that they can do to reduce their fall risk, and then whatever else we need to talk about. It's often referrals to different services, etc. And then there's a summary station where they may get their vision screened. They talk about a little bit of action planning. How do you think you can manage these recommendations, etc. And then after all of that, we send a letter back to the referring professional and the family doctor just to summarize what we've discussed. And then there are follow-up calls about 3 months later. So that's how we've done it for a long time. This is the PPA results that we actually share with the clients. So the PPA domains include contrast, vision, proprioception, leg strength, reaction time, and balance. And this is a fairly typical example of someone that we would see. So if you've not seen one of these reports before, it's a graph of falls risk versus age. And the age graph starts at about 20, not that we see very many people in that age range, and goes to about 100. And the light blue area is the average fall risk at any given age. Most of our participants are in the sort of 70 to 90 range. This individual would have been sort of in the 83-ish age range. I can tell by going down the red dot is where they plotted. So this person is about 83 years old and is at the very top end of the risk for their age group. We ideally would like people to be at least within the norm. And what we do is we look at the actual domain. So this particular individual, they actually had a raw score here. This was a woman over the age of 84 or 84 or more. So this is the target group that they've been compared against, and this is how this individual compared to age-matched and gender-matched targets. So this individual, their contrast vision was within the average range. Their leg position sense, so proprioception, was within the average range. They were in the below average range for strength, reaction time, and balance. And of course, we know that if you have weakness and poor balance, you're at a higher risk of falls. And if you have poor reaction time, you're less likely to catch yourself. So that combination is absolutely going to put this person at the highest risk category. So the thing that we'll tell them at the clinic is, strength and balance are absolutely things that we can work on. Reaction time may improve with exercise as well, with certain types of exercise. So we'll go through strengthening and balancing exercises with them, give them a bunch of different suggestions. So our clinic has actually been involved in a fair bit of research. Our previous director, who is the sort of brain behind the Fall Prevention Mobile Clinic, is Dr. Fabio Feldman, and he's fairly well known within the falls community. Unfortunately, during the pandemic, he left us and went to the cancer agency. So we're now sort of going without him, but his legacy is this clinic, and they started with a lot of research. They did a study in 2009 through 2012 about the clinic to see if it was actually helpful. But the idea behind it was they really wanted to see whether clients were actually following the recommendations that were made. And then my former colleague, Ashley Collins Kwan, did a seed grant. A seed grant is a $5,000 grant that's provided by Fraser Health to see if there was a change in uptake when we added various behavior strategies. I'll talk a little bit about that. And then I actually had a seed grant a few years ago about whether it was feasible to do the exercises via telephone. So we'll talk a little bit about that as well. Basically, the key points from the previous research was that the most common recommendation from the clinic is exercise. Surprise, surprise. I mean, there's a physio there, right? So basically everybody gets homework. And I tell them that when you come in, you will have homework. So I think this is my predecessor, only 99% got feedback, got exercises. I would say probably 100%. However, when they looked at the uptake with the recommendations, when they looked later, only 27% of people that attended the clinic actually did the exercises that were recommended. So it's a not very good uptake. And of course, we all know that exercise is a huge, huge factor in falls reduction. So that was a bit of a concern. Lots of the other recommendations were made, including bone health. So that includes things like going to get a bone density test if they're, deemed as being at risk. The pharmacist usually does a FRAX and so on. Calcium supplements, vitamin D supplements, blood pressure monitoring, et cetera, et cetera. So when they looked at which recommendations were people most likely to do, they would get their blood pressure monitored, or they would go for a vision check, or they would have their medications reviewed or their pain management looked at, or take calcium. But as I said, the exercise was not a high level of uptake. So after that, with the seed grant that Ashley did, they added sort of some goal planning and self-monitoring tools and an action plan, so that when people were on their way out the door, we'd say, okay, so these are the goals, like these are what we've recommended that you do, and this is the tracking sheet where you can keep track of the exercises that you're meant to be doing, and what are your goals, and this is your action plan. And then they also added, during the seed grant, some coaching, some in-person coaching or telephone coaching, and they found that helped the uptake. The challenge, of course, is we don't have a lot of bodies to do this work. So for each of the studies that have been done, they've always looked at the fall risk as kind of a secondary outcome to see if it changes. And it consistently has shown that coming to our clinic has had a decreased fall risk after the clinic. So we would do the initial assessment and then bring them back in 6 months or a year or whatever and retest their falls risk with the PPA and see if it's changed. And the trend has always been that there is a decrease in risk. In fact, people have gone down 1 or 2 categories on that color graph. So they might have gone from the very high category to the moderate category, or from the high category to the mild category, which is significant clinically and personally for the client. But they did find, of course, that if you had an improvement in your PPA score, it was usually because you actually followed the recommendations. And it's pretty clear when someone comes back for a follow-up, when we see them, that whether they have or have not been doing the recommendations just by looking at the PPA score. Obviously, when we added the behavior change strategies, there was an improvement in falls risk. So on this little graph here, it shows that like group A was the control group where they just got given their recommendations and that was about it. And then group B, they had a short sort of brief action planning session with the with Ashley before they went out the door. And then group C, there was like that full coaching either by telephone or online. And so there was an increase with the full coaching, but even just with the action planning piece, it was huge. So we tried to adopt some of that in our clinic. But basically, the question ended up being, how do we get people to do the exercises? Because we know that this is important, and there's obviously some issues with getting them done. So I did a telephone exercise seed grant in 2018 and 2019, and it was just a feasibility study. It was very small numbers, but the question was, can we do exercises on the telephone? And the reason we chose that as a question was that a lot of our seniors don't really have access to technology, or haven't had access to technology. So like virtual, at that point, virtual care was not really a thing. Obviously things have changed, but we started doing the old school telephone calls. So what happened was someone would come and see me in the clinic. I don't just give them the piece of paper and say, go do these exercises. I don't believe in doing that, because I don't feel that that's as effective. I actually make them do the exercises with me in the clinic. So we do them together, and I'll correct how they're doing them. And I'm probably a lot pickier on how people do the exercises than some people, but that's just the way it is. So they go through the exercises with me in the clinic, and then they get this tracking sheet. And then so the ones who did the study with me, I would actually phone them twice a week. So we would set up a phone date. Initially, their first phone call would be 1-to-1, where we make sure they're still up for doing this and make sure that they had, a hands-free speakerphone so that they could put the phone on the counter and have their hands available for the exercises. And we would actually go through the exercises together. So there I would be in my little glass-walled room in the office doing exercises with people walking by thinking, what is that crazy person doing in that room? But anyway, and then after about 3 months, we had them come back to the clinic and do a retest. And again, the primary outcome for this was, since it was a feasibility study, was like, is it even possible to do this? And what do clients think about this whole idea of doing exercises on the telephone? And then we also looked, as I said, at the PPA, the short form PPA. We also did the activities and balance confidence scale and the IPAC, so the physical activity questionnaire. And so with that group, we had about 29 participants. Like I said, it was very small. 72% of which was female. That's not unusual. And the age group was quite spread, but the large majority, this is the 65 to 69 group, the large majority was over 70. And we did have more than half of them in the over 75 age group. The average age was 78. And after that, I asked them for feedback. And basically the feedback I was getting was, I feel more confident about my balance. I can bench, take my socks off. There was one lady that said, I was walking down the hall at the doctor's office, and it's a long hall. And every time I've gone to the doctor's office, I've been weaving and bumping into the wall. And now I can walk straight and strong. And I was like, that is fantastic, because it clearly made a difference to this woman's life. And a lot of people found that they'd had difficulty doing exercises in the past, but just because I was phoning them and bugging them to do the exercises with me, they were able to get it done, and they felt a lot of benefit from it. So the themes, when we sort of looked at the thematic analysis of what the feedback said, was that some of them, it made them realize that exercise was actually important, where they hadn't really thought that in the past. And a lot of them found that their balance increased. Some of them noticed some increased strength. The motivation was important. So knowing that someone was going to call you and that check in on you. Some of them, they found that it was able to increase their ability to walk or be mobile and decrease their risk of falling. And then, of course, it's quite convenient for them because they don't have to go anywhere. They don't have to get dressed. They're just on the end of a telephone. And then when we asked them in the end, did it benefit you? The large majority of them said, at least somewhat, 25% somewhat. We had one individual who was, he was kind of a grumpy old man. And he was quite fun, but he really was quite, I'm not sure why he agreed to join the program. I think he didn't, I don't know. Anyway, he didn't particularly want to be there. And he's the one person who said there really wasn't much benefit. But when you looked at his PPA score, it actually was huge, the difference. So I thought it quite interesting that he was the one individual that said, nah, it really didn't do that much for me. And he is also the one individual who said, no, I wouldn't do that again. But everybody else was much more positive about the experience. This is basically the picture that we would see, the PPA risk that we would see pre. So when we looked at all of those 29 participants, their average score was 1.7 on the PPA, which put them well into the moderate risk category. And then their post-program PPA ended up right on the border between moderate and mild risk. So that's a fairly significant drop for people. So then 2020 came along and we had a global pandemic. And all of a sudden the community centers were closed and everybody's in lockdown and in isolation. And we have all these frail seniors who were already at risk and now are at more risk because they are afraid to go out and they can't get any exercise and they have nobody coming in. And we had to stop the clinics because, of course, all the community centers in the province were closed and people are still falling. The pandemic's not stopping that from happening. And our wait list is getting longer and longer. And we were trying to figure out, well, how are we going to provide services to these people? We need, we didn't want to stop the clinic. And this was really our primary job to do these clinics. So we sort of started thinking outside the box and deciding we needed to do true virtual care because there was a policy within Fraser Health that said virtual care first. So wherever possible, if you can provide virtual care, you need to. So that brings me to a poll question. I'm just curious, given that we've been in a pandemic for 19 months or however long it's been, how many people are providing virtual care and which platforms they're using. I'm assuming we'll see the results shortly.
Yep, we've just got a couple more participants trickling in. So, it's slowing down now though. Give me one sec.
Okay, so wow, 76% of us are doing virtual care now. That's great. I mean, how many, I guess the other question was how many of you were providing virtual care 2 years ago? Because that would have been interesting. And a lot of people are doing a combination of telephone and video. Okay, and then I'm curious about the other too, because maybe in the Q&A box or whatever, if you want to let us know what you're using that's other, I'd be curious because I'm always looking for other options. Okay. So, I mean, why did we start a virtual clinic? Well, obviously with COVID, we had no choice and our in-person clinics were canceled. And like I said, all these people are isolated. And we still felt that it allowed for a somewhat personal connection, and it allows for us to try and provide as much safe care as possible. So we actually were early adopters, I would say. We started in April of 2020 because the axe came down. I think our last clinic was like, I want to say it was March 14th or something. It was like the day before the border closed. And so we didn't have very many people that day because people were scared, but that was our last clinic. And when we looked at doing this, there wasn't anything out there. There was no direction from the powers that be because it just caught everybody off guard. And, they're worried about like acute care and COVID and stuff. They're not worried about, whether the physio from the fall prevention clinic wants to do virtual care. But they did say that we could start using Zoom or FaceTime. So we were authorized to use those two platforms. And of course we have the Zoom for Health, which doesn't, store its stuff offshore, blah, blah, blah. So our team worked very busily to develop a virtual intake package so we could ask a lot of those history questions before we actually saw them. And we started drafting virtual assessment forms. I think we've got to version 11 by now. Like, I think we had a lot of little changes along the way, and they started booking the appointments with the pharmacist and with myself. One thing actually that's probably good to note is that within Fraser Health was actually quite an early adopter of online charting through the health authority. So anybody who's been seen within like a hospital or a health authority service within Fraser Health, we have electronic documentation for that. And so that's really helpful because when someone's referred to us and we have their personal health number, I can go in and see, how many times they've been in the hospital, how many times they've been in ER, what their medical history is. And it makes it a little bit easier because some of our people are not the best historians. When we talk to them on the intake, we ask them their personal information, name, address, et cetera, where they live, what their pain is like, what their fall history is like, if they have a blood pressure monitor, because some people do have blood pressure monitors at home, we'll ask them to take their blood pressure. The pharmacist will review all of their current medications. And of course, our pharmacists are able to see their medications through PharmaNet, which is another electronic charting where they can see which medications have been prescribed and so on. They calculate the FRAX and they'll make the recommendations. And like I said, my job is really to do sort of the functional mobility and activity piece. I do a virtual balance and gait assessment. I give them home exercises. And again, I actually make them do them with me. Provide all kinds of different recommendations and resources and referrals, equipment recommendations and so on. Before I was in this job, I was in home health, and we did a lot of, we did a lot of the basic equipment like raised toilet seats and so on, because OT was a lot more specialized with seating and wheelchairs and some of the more complex accessibility issues. But things like a raised toilet seat or a bed assist rail or whatever, that's anybody's area. So when we started the virtual physio assessment, the one thing I said is I have to have video. I can't do an assessment of somebody's balance safely without being able to see them. And initially we said, you need to have a support person there with you, because if something happens, somebody needs to be there. And then it became pretty obvious pretty quickly that a lot of these individuals were all by themselves. They didn't have a support person, and they didn't even have family that was coming in to visit them because everybody's afraid of bringing COVID in or getting COVID or whatever. So these people were very, very isolated, and that became kind of a barrier for us being able to see people. So we sort of had to relax our criteria a little bit. And I do always make sure that I have their address, their correct address, just in case, because if I ever have to call 911 on somebody, I don't want to have say, oh, I don't actually know their address and there's nobody there that can help me. So we do make sure we have their address. If they use a gate aid, I want to see them use the gate aid. I want to see how they normally would use it. And the most important thing for me is to be able to see the client standing at a support, ideally the kitchen counter. I have to say that that's been a huge challenge in some cases, trying to set up the device in such a way that I can see the entire client's body standing at a counter. You know, if they have a desktop, they can't move it.
Hi, everyone. It looks like Rhonda is frozen. I'm thinking it's not just me because I've seen some messages about it. We'll just give Rhonda a second to hopefully reconnect. Hi, sorry, I was just on the phone with Rhonda, so I think that was messing up the audio. Oh, I think she might be with us.
I can hear you now. Can you hear me?
I can hear you. Can someone else confirm that they can hear Rhonda?
I can hear her.
Fantastic.
Oh my gosh.
Thank you, everyone.
Isn't that embarrassing? And that's the whole world of virtual health. Like, holy cow. So I don't know what happened. They're doing work on our street. They're actually installing fiber optic. And I think part of that is because I went through a period earlier this year where I got kicked out of Zoom calls 11 times in one day, 11 times, which was extremely frustrating. And I actually went to the city and I went to TELUS and I basically told them that this was not acceptable. Anyway, here we are several months later and they are actually installing fiber in my area now. But I have since changed servers and I haven't had any problems until today. So isn't that typical? Anyway, I was actually still on the slide about the virtual assessment. And we were talking a little bit about the fact that I need to be able to, that one. The see them at the counter and then what tests I use. So I actually, when I was trying to figure out how am I going to do a virtual assessment with people, I need to do something that I don't actually need to put my hands on them, or that's, you know, it makes it that's simple and something that I can do remotely. And the only thing I could figure out was anybody who's familiar with the Tinetti Gait and Balance tick scale, which is also called POMA. Almost all of the parts of that can be done virtually. There's one part, which is the nudge test, where you go up and push them and see if they fall over. And clearly I can't do that through the computer. We do the 5-time sit stand and we do the 4-stage balance test. So yes, please, if you can go ahead there, Michelle, that'd be great. I just put the images there, like the 4-stage balance test. That's the standing narrow base stance, and then semi-tandem and full tandem and standing on one leg. And in each position, we ask them to see if they can take their hands off the counter and stand for 10 seconds unsupported. This is kind of my fillable Tinetti Gait and Balance form. And as you can see under the nudge category, it's not applicable. So I give them a score out of 14 for the balance part and out of 12 for the gait assessment. And that gives a combined score of 26. So this hasn't been, you know, this is something that I just have had to do. And it's not something that they have modified. It's something that I have modified on my end. I'm hoping they're okay with it given the situation. So some of the recommendations that I make on a regular basis, if we want to move forward there, Michelle, is obviously home exercises for strength and balance. And we do use the SAIL program here, which is Strategies and Actions for Independent Living. And the SAIL program has 3 levels. The first level is sitting. Virtually everybody who gets referred to our clinic is able to stand, because really they can't participate that well in our clinic if they can't stand. So I do use the standing exercises, and actually most of the people that come to see us, particularly in a clinic, are mobile enough to get out into the community. So therefore I actually use the SAIL moving exercises quite regularly. And those are the slightly more advanced ones, like standing on one leg and walking on the tightrope, etc. We always talk about various types of aerobic exercise, like, you know, walking and stationary biking and whatever else they want to do. I talk a lot about the home safety equipment, so gait aids and bath safety and transfer equipment, and we talk about hip protectors, and I refer them to the whatever I can think of in the community or virtual exercise classes. So it's a little bit challenging for me sometimes because I got such a huge geographical area, and I kind of have to know what exercise classes are available in each community. And I don't always know exactly what's going on, but I do try, we'll look at the local rec guide to see what's happening. There hasn't been a lot happening over the pandemic, so it's been more virtual exercise classes. And so we've made a lot of recommendations in that area. So next slide, please. I make a lot of referrals to various different places. So sometimes people need to be referred to either outpatient physio or private physio. We seem to have a lot of people that have vestibular problems, which probably makes sense. And that's why they're having falls and coming in. And we have a lot of, vestibular therapists that work privately in the community. So I do make a lot of referrals to vestibular therapy or private physiotherapy, whether it's for neurological issues or, just general musculoskeletal issues. I have tried to make some referrals to our Fraser Health outpatient. They have very strict criteria, and I'm not always successful in getting people in to see the outpatient physio. In some cases, when we do have people that are really quite frail or there's significant concerns about their home environment, I will refer them to home health. Because I used to work in home health, I also know a lot of the home health staff and in various offices. So I'll often run it by them, or what I can do is, I can, if they're already known to home health, like perhaps they're known to nursing and home health, I can contact the home health nursing staff and say, I think you need to refer this person to OT or to PT or whatever. We have a lot of people with Parkinson's that get referred to us. And so I make regular referrals to the Parkinson's Society and other allied health. We've referred people for swallow tests. We've referred them for OT, et cetera. I fill out lots of handy dart forms. So that's in BC, that's our disabled transit system. And then there's other societies like the MS Society and Alzheimer's and so on, that often people have health issues and they don't have a huge knowledge about them, or they don't have a lot of support with them. So these other societies can be very helpful. All right, next. So technological challenges. Call drop. So that's obviously a big one. On behalf of our clients, we've had a lot of issues because they just don't have a device that has a webcam or has whatever. Or sometimes they have difficulty downloading Zoom or joining by internet or whatever. And then some of the limitations of the platform. So the reason I like Zoom is that I can screen share and show people the documents that I'm talking about and so on. We are allowed to use FaceTime, but I don't particularly care much for FaceTime because I can't screen share. And I'm really thankful today that Michelle has my slides so that she can show them, because otherwise, with me being on my telephone, that wouldn't be happening. All right, next. So one thing that we have noticed in sort of the human challenge category, like I said, we have a lot of clients. Most of our clients are in their late 70s, early 80s, and many of them have very limited digital literacy. They have some of them don't even know how to turn on their computer. The idea of downloading a program is just not something that they're able to manage. And there's a lot of anxiety about doing a virtual visit. Especially if they don't have a support person available. I think one of the best early appointments I ever did was with someone who had an 18-year-old grandchild who was studying to be a physio or a rehab assistant. And it was awesome because the grandchild was right there, had everything set up, was able to do all these. It was remarkable because that's not typical. Sometimes they don't have anybody, or sometimes their support person is also having issues with digital literacy. And then, like I said earlier, trying to set up the device in such a way that I can actually see them can be really challenging, especially if it's something like a tablet where there's no way to put it forward. Anyway, let's go. So far, apparently, according to our stats, I've done 230 virtual physio visits, and the pharmacist has done about 270. The reason for that is that the pharmacy visits can be done over the phone. They don't actually need to have video. So some people have been seen by the pharmacist and not by myself. And 227 have been seen by both of us. There were a couple people that were actually already well connected with pharmacy, like home health pharmacy or the specialized seniors clinic. So they didn't need to see the pharmacist, but 227 have been seen by both of us. We have been asking people to fill out a feedback form. And I actually have it on the bottom of every email. Please provide feedback. So that's why there's more feedback about me. There's 94.1% of the people that have filled out the feedback have filled it out about the physio. But we've only had 17 people out of those 230 that have actually provided feedback. But when we asked them, have you done a virtual healthcare visit before? Most of them said no. Of the ones who said yes, most of those had their pharmacy visit before they had their physio visit. And then we asked them, how confident are you using technology before your visit? And you can see that, a few people were not at all confident or kind of confident. There were a few that were confident, which was great. So then we asked them after this visit, did it meet your expectations? What about the technology? So there were a couple of people that said it was not as good as they expected. And I think that was especially during that period that I was talking about where I was having significant internet issues and I ended up having to change my server and so on, because we had a lot of dropped calls in that time. And like I said, 11 in one day, it was just crazy. But then still, most people felt like it went way better than they thought it was going to. So that was good news. And then we also asked them afterwards, from a health information perspective, like the information that we gave you, did it meet your expectations? And everybody said it was either better than expected or much better than expected. So that was kind of nice to hear. And then we asked them if they would recommend the clinic to everybody else. And almost everybody said yes. One was wishy-washy, but everybody else said either yes or definitely yes. And then we asked them for feedback. And so this is some of the feedback we've had about the course. My favorite one was way too much new information, must go to the pub and have a good think. But the rest of it was, people were really appreciative of the way that the visit happened, and they found that the information was helpful, and that they mentioned engaging, and that we tried to keep it interesting. So that was good. We also asked them, what could we do to make it better? And my favorite answer to that was provide coffee and donuts. But unfortunately, we couldn't figure out how to do that. So overall, it seems like this virtual care is well received by the participants, and most people find it to be beneficial. I spend a lot of time talking to them, like an hour and a half. It's a really long call, and they have to be able to attend for that long period of time. The pharmacist's call is much shorter than that. It's only about a half an hour. But overall, we do feel like this is a tool that can be useful for our clients that are in a remote situation. So when we're looking at like implementing a clinic, the things that I would say are important to think about are whether the client is suitable. So do they have the cognitive ability to do these things? Do they have the technological requirements? Are they willing to do it? Because honestly, we all know that if people don't want to do this, they're not going to do it. They're not going to get much out of it. Can they follow instructions, and can they actually do a video visit like cognitively? Then we have to set up the appointments. And I have to say, my team has been so amazing in learning how to support these people who have no idea how to hook onto Zoom or whatever. And you know, kudos to my team, because they spend hours trying to help some of these people get connected. We now have a virtual concierge with Fraser Health. And so that team is meant to do that. But of course, we started way before that did. And then once we get the information, of course, we have to document it. So then the next thing was like with the recommendations, we have to assess them. So like I said, I'm using, I watch them walking with their gait aids, or if they have more than one gait aid, they sometimes use, I'll watch them hopefully with both. We do the 5 times sit stand, 4-stage balance, the Tinetti gait and balance. We also try to look at their environment. There's been times where they've had like a phone or a iPad, and they've taken it into the bathroom to actually show me what the bathroom looks like, or show me what their bed looks like, or whatever. So we talk about equipment needs as well. Talk about, well, you know, I see you've got a rug on the floor there that's in the middle of your traffic. You know, have you ever thought about moving it out of the way or whatever? And we also have to assess their willingness to do the exercises. And then, like I said, I don't believe in just giving people the papers. I actually want them to try the exercises with me, and I want to see them try it and make sure it's safe. So then we get to sort of the fact that, you know, exercise, the recommendations, obviously safety is number one. We always have to be safe. So I have them standing in a position where they have something solid for hand support. And when we do the exercises, usually these are things that people have never done before, haven't done in a long time. And I really believe in starting them with just a few repetitions. I am very conscious about making them do their exercises slowly. I see so many people that are like up, down, up, down, up, down, up, down, and they're not actually making their muscles work. They're using speed and momentum. So I'm always really making sure that I tell them, I want you to do this slowly. Especially my most favorite exercise is slow sitting. So, you know, they call it sit to stand on the SAIL program. I call it slow sitting, because I'm actually more concerned about how they're sitting in some cases than how they're standing. So I make them sit very, very slowly. Don't plop, pretend there's an egg in your chair, blah, 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 sit like a feather. And I'm checking in with them frequently. If they need to take a rest break, they take a rest break, because that's important. And I really tell them often, you're better off to start with just a few of these and do them more often. So maybe to begin with, do 3 or 4 repetitions, but try and do them a couple or 3 times a day. And then when they get easier, you can do more of them and not do them as often. So the other thing that we do is we do a lot of virtual fall prevention presentations. We always did fall prevention presentations, our team. We would, again, go out to community centers or assisted living environments, but now we started to do those virtually as well. And we've actually had a couple of, we have what we call out here the senior center without walls. And again, we have a lot of people in our target group that don't have technology, but they do have a telephone. So there's this very interesting, I don't even know what the name of the system is, I can't remember, but they have this telephone system where they have the senior center with walls, and they get a telephone call, and as long as they answer the call, they're put into this group call. And so we've actually done some fall prevention presentations on the telephone, which is different, obviously, than being able to show people a presentation or video, or get them to do what you're doing. But it's still had good feedback from that. And there's now more, like compared to 18 months ago, there are way more virtual exercise programs out there. Sometimes the difficulty is weeding through the ones to figure out what's going to be the most appropriate for a client. We've also talked, you know, with virtual options, there's like Zoom exercise classes, and there's pre-recorded exercise classes, so they can do it any time of the day or night on their own. And there are actually some telephone activity programs as well. I have no idea if we're ever going to return to quote normal, unquote. Regardless, I think it's safe to say that virtual care is going to be here to stay. They're still saying virtual care first for Fraser Health. So as much as possible, when we can do a virtual visit, they want us to. So basically, I mean, my conclusion is that if you haven't embraced virtual rehab, now is probably the time to do that. You know, this whole global situation has resulted in a massive change in the way we practice. I will say, you know, when I graduated from physio school, we didn't have the internet, right? That was a number of years ago. So the idea of doing a virtual physiotherapy assessment was really outside of my frame of reference. I mean, if people who are graduating now, it's like, ah, yeah, whatever. But when there wasn't even an internet, it's a bit of a mind shift. But one thing I've learned is that this can be a really beneficial tool. And I think it will still be utilized after the pandemic. But of course, obviously, the most important thing is that the care is safe and that we're providing good quality. And we do have a lot of resources we can draw on. So the question is, what's stopping you? So the quick poll question is, how many people think they are going to provide virtual care in the future? And while we're waiting for that poll result, I'll just keep talking because I know I'm running out of time. So there is still work we need to do. I mean, we haven't been able to truly assess the effectiveness of the mobile clinic. Part of that is that, you know, we used to, when we were, oh, here we go. 64% say definitely, and 32% say possibly. There's only 4% that are saying only as a last resort. So that's good news. So the problem with assessing what I meant, sorry, this shouldn't say mobile clinic, it should say virtual clinic on this slide. And the difficulty is how to determine how effective it is. So we can try to go back and figure out if they did the recommendations that were made. And we can try to go back and see if we can find a change in the number of falls or in the falls risk. But it's difficult because before, when we were doing our mobile clinic research, we had the PPA, which was very much an objective category versus it's a little bit more subjective when we're doing virtual. So we have talked about ongoing fall prevention exercise classes, either via telephone or video conference. Staffing's the big issue. Like, there's only one of me and there's only one of my colleague who's the coordinator, and we just don't have the time in between virtual clinics and regular clinics, and I'm doing the Healthy Bones clinics and blah, blah, blah. So that's kind of the work that we need to do that we haven't done yet, but I'm done talking. If there's a couple of questions, I would be happy to answer them quickly.
Thank you so much, Rhonda. There might be a couple of questions that we could answer in the next 2 minutes. Before we do that, I just want to make sure that everyone knows that there is going to be a link to an evaluation survey that will be sent to everyone when they hop off the webinar. But I really do want to thank you, Rhonda, for your wonderful presentation and for being a champ at managing virtual difficulties. That is an interesting way to prove your point, to have your internet drop out.
I wasn't planning that. Actually, one other thing I forgot to say is sometimes we have people that can't get the audio piece done, but we can get the video done. So then in that case, I have the Zoom on so I can watch them, but I'm actually talking to them over the telephone. So very much like what we did today. So that's interesting. It's not the first time I've had to try and think on the fly.
Yeah, absolutely. I think there's one question that's kind of come up in a couple of different iterations. So I'll share that one, and then I'll let everyone know that we do save the questions that do go unanswered, and I'll provide those to Rhonda, and she'll be able to either reach out directly to you to answer them, or we can post a document sharing those answers on Loop. So the one question that has kind of come up in different iterations was, have you had any incidents, safety issues, and how did you get around this having a support person there?
So the only safety incident that I had was I had client who had advanced, I'm not sure if it was Parkinson's or PSP, but she like falls 6 times a week anyway. And during my actual virtual visit, she did fall. She was unharmed. And she, you know, like I said, it was something that she falls all the time. And she declined me, like I told her to go to her doctor, but she declined any emergency assistance because she just got back up and was, you know, fine. It was terrifying, I think more for me than for her. But for the most part, you know, like I said, I try to manage it by having the address and phone number and so on. So if I need to call emergency, I can. But knock on wood, it's largely been okay. And if there are concerns, like if I'm doing a balance assessment with somebody and they're clearly not, then we just abort. Like that's okay. That's obviously that task is not going to happen. And I sometimes, like if they got really bad knees, I'll skip doing the 5 times sit stand because I know it's just going to make them worse or whatever. A lot of it's just clinical judgment.
Well, thank you again. We're just 1 minute over time, which is impressive given our technical challenges and all of the fantastic info that you jam-packed into that webinar. Thank you so much again, Rhonda. And thank you for joining us, everyone. And we hope you have a wonderful afternoon and a fantastic weekend. Thanks again.